speaker. Pat Scow is the Executive Director of the Illinois Critical Access Hospital Network, or ICANN, the first statewide critical access hospital network established in 2003, comprising of 55 critical access hospitals and rural hospitals. ICANN is providing a number of hospital support services and educational programs, as well as managing the Medical Rural Hospital Flexibility Grant, Small Hospital Improvement Program, and several other grant programs on behalf of the Illinois Department of Public Health. In addition, Pat is the Executive Director of the Illinois Rural Community Care Organization, which is a statewide rural accountable care organization comprised of 24 critical access and rural hospitals. Pat has more than 35 years of clinical and rural hospital administrative experience and currently serves as Secretary of the National Rural Health Association. She was awarded the Calico Rural Leadership Award by the National Rural Research Center in 2013 and received the National Rural Health Association's President Award in 2015. She has served as Chair of the Local Health Board for more than 20 years. Pat is a fellow member of the American College of Healthcare Executives and national speaker and facilitator. And we're very lucky to have her here today. Now I'll turn it over to Pat.
Okay, good afternoon, and thank you for joining the webinar call today. Hello, can you hear me?
Oh my God.
Hello, can you hear me? Hello? I think you need to unmute me. Hello? Can you hear me? Can you hear me?
We can hear you.
Okay, all right, I'll go ahead then. Thank you.
I don't know. Yeah, I don't know what happened.
Hello?
To...
Hello?
Hello?
The organizer has disconnected, and this conference will continue for 60 minutes.
Hello? Can anyone hear me? Pat, if you're there, press *2.
Yes, we can hear you. I can anyway.
Oh, okay, great. Did anyone hear my introduction that I gave, or was that to no one? Okay,
no.
Apparently
no, we heard it.
Okay, sorry about that, everyone. I had some connection issues, but I was just introducing Pat Scow, our speaker for today's webinar, Alternative Payment Models, Business Perspective. And Pat, are you on the line right now? I see that Pat is on the webinar portion, but I don't see her on the I don't hear her on the phone. I'm going to give her a moment just to call back in and just do a really short introduction for Pat, and hopefully she will be able to call in the next couple seconds here. Pat Scow is the Executive Director of the Illinois Critical Access Hospital Network, or ICANN, the first statewide critical access hospital network established in 2003, comprising of 55 critical access hospitals and rural hospitals. ICANN is providing a number of hospital support services and educational programs, as well as managing the Medical Rural Hospital Flexibility Grant, Small Hospital Improvement Program, and several other grant programs on behalf of the Illinois Department of Public Health. In addition, Pat is the Executive Director of the Illinois Rural Community Care Organization, which is a statewide rural accountable care organization comprised of 24 critical access and rural hospitals. Pat has more than 35 years of clinical and rural hospital administrative experience and currently serves as Secretary of the National Rural Health Association. She was awarded the Calico Rural Leadership Award by the National Rural Research Center in 2013 and received the National Rural Health Association's President Award in 2015. She has served as chair of the Local Health Board for more than 20 years. Pat is a fellow member of the American College Healthcare Executives and a national speaker and facilitator. Pat, are you back on the call?
I hope so.
Oh,
can you hear
there
me?
you are. Yeah, I can hear you, and I really apologize there. I had some connection issues. So I was introducing you and going through the beginning, but anyways, I'm glad we are all back on here. Yes.
Enough said. Thank you for allowing me
to
Okay, thank you for allowing me to present, and I know everybody's time is valuable, so I'll move along with the discussion, and I really appreciate the opportunity, and it's I think I know a few of the names on the call, so it's nice to connect again. I had the task of talking to you about alternative payment models, and probably because the fact that I've been working with our rural ACO, so I'll try to pull in what's going on in the environment and talk a little bit about our ACO and what I think is going to be moving towards in the future. I put together an agenda of things that I'm going to cover, besides my summary that I just gave you. I talk a little bit about ICANN, the Critical Access Program, volume to value, and really dealing with the ROI as we move forward with the new delivery system. So I think most of you are probably familiar with ICANN, but we're a 501c non-for-profit and cover the state of Illinois, have all 51 critical access hospitals, plus 4 non-critical access hospitals that are part of our organization. And I've given you just a breakdown of what we look like. We're still fairly independent. We have very few still doing OB care, some long-term care, and so forth. And I think what's significant and what really ties us into the conversation today is that from ICANN we launched Illinois Rural Community Care Organization, which really allowed us to apply to become a Medicare shared savings program and an accountable care. So we'll talk about that in a few minutes. So moving ahead, I thought it was important to talk a little bit about the critical access program, because I have to believe that most all of you are. As you know, the Medicare program is about 20 years old now. It was passed in 1997. However, it took a couple of years to launch. But the program is cost-based, and that's the system we're in today. We're concerned about swing beds. There's a lot of discussion. Should we, swing beds paid too much? Should we have a little more flexibility with our swing beds? Medicare Advantage programs are growing, and that affects a little bit traditional reimbursement with critical access. There's a great movement to focus on wellness. We have hospitalist programs. Most of our hospitals now own physician practices and clinics, and all these things are really coming into volition, and what the critical access of the rural environment looked like 20 years ago is different today. And I think we have to think about, and that's why we have to be open-minded to new systems out there. I thought I would start out, I did a survey of all the 55 hospitals last January and really talked to each one of the CEOs. And I'm using Tracy, she's my president-elect. I spoke at her hospital a few weeks ago. And this was a summary of what they felt was really impacting their business today. Obviously, physician recruitment. There's surprisingly an RN shortage. We continue to have leakage. It's hard to keep the patients locally. We don't have a good system for coordinating care back to our organizations. Now, I don't think any of you are living in Illinois, so you don't have to deal with the messiness that we have with Medicaid. Even though we did expand Medicaid, we still have difficulty getting paid in a timely fashion. We're having payment system reform, and will that affect our current cost-based reimbursement? Our hospitals are really concerned about that. They're, always ask me, Pat, is the CH program still good to go? Swing bed program changes, life safety upgrades, leadership development. We will soon have more baby boomers turning over, not only at the senior level, but also as your department directors and so forth. And we really have to deal with the culture change that's coming, with value-based purchasing and the move towards population population health. So, just looking at it in whole is, we know there's still the soaring healthcare costs. I think our hospitals, we've all worked hard to bring our costs under control, but we still have escalating pharmacy costs and other factors that enter into it. That debate of Affordable Care Act, replace or not, commercial carriers are moving to value. I've got several calls of recently with commercial carriers in Illinois that they would like us to move into their accountable care organizations that they have. Many of the Medicaid programs are looking to manage care and not being run by the state. Global payments look at Pennsylvania and Maryland and, bundling patients, bundling payments for the patient care that we give. Gosh, who'd ever thought about that years ago? We still have hospital closures. We had one in Illinois about a year ago. Haven't had any of recent, and that number still grows. Competition, 20 years ago we really didn't have competition to the extent we have today. And part of that's the changing environment. And most significantly is, last year was the passage of MACRA, the Sustainable Growth Rate, that whole program, done, and we're moving towards this incentive program. So that's really going to change how we do business. We also know that population health management, we have to think about our community. How many community needs assessments are you doing? One every 3 years. I live in Princeton, Illinois, which is in Bureau County. It's kind of north central of Illinois, and we're fairly rural. There's about 30-some thousand in the county, but a lot of small little pockets of care, and we really are rural. My office, I actually look out at cornfields. So downtown is small. We've got about 8,000 population. So when you think about healthcare, you have to think about your community, and I describe modeling, and we're going to be responsible for our community. It's not just they come and get, their stitches removed and away they go. Hospitals and practices, we're having greater accountability. And I think this is just a summary of what we've been going through the last number of years of the healthcare reform. The triple aim has become centerfold, and we're really looking at how our market shares are changing and traditional care of how we manage things are really more moving towards integrated networks. However, I really think what's foremost in there is that primary care driven, and I think that's a real plus, and I'll talk about that as we move forward for our rural hospitals. And then, of course, the movement to accountable care organizations. So moving to volume, from volume to value, really the change came about with the SGR, when that's gone. And we're in this QAPI or quality payment program and the incentive program for payment, that 10% swing every year. And then, the possibility of, if you're in an alternative payment model, the 5% initiative and incentive there. So, thinking about the details of Medicare incentive program, and that's not really the purpose of this program, is to go to do a deep dive into it. I know Dr. Davis, who's the Chief Medical Officer with our organization, is going to talk about that more, and I'm sure Kim and her group will have more programs on that. But I do have to frame it knowing that, we do have more performance area, quality, advancing care information, appointment activities, and practitioners are going to be scored on that. And this is the year that they're going to have to do some reporting, at least for 90 days. So you're thinking, how does this break down? And you can see, it's still relatively all quality, 60%. And as we move closer towards 2020, these percentages change, and physicians will have to be more involved in improvement activities and in controlling their costs. So all this stuff, you're thinking, why is it driving this? And why advanced alternative payment? It's not just accountable care organizations. There's other programs, the end-stage renal disease, comprehensive primary care, and maybe some of your hospitals are in there. All these next-generation ACO models and the shared savings programs that we're in. Now, we're in track 1, which is no downside risk. And even though we're somewhat protective in that we have an aggregate score for our MIPS, but we have to move to a more advanced model to get the consistent 5% payment. And there's other advanced payment models. So you can see that CMS and other organizations are moving us towards, slowly pushing us towards, some type of a risk-bearing program. So let's talk a little bit more about accountable care organization, and I just simply took this from Centers for Medicare and Medicaid, and it's really hospitals and providers coming together to agree to coordinate care. Now, from the Medicare perspective, for Medicare. Now, you can easily substitute Blue Cross Blue Shield, Aetna into any of these things. And our goal is to coordinate care. And that's part of the reason the focus is on coordinated care, is controlling risk. And if we do so, that we can improve the care and, of course, decrease cost. And, there's various models. There's various ACOs, from commercial to, the different types of shared savings program. And I can certainly entertain a lot of questions as we move forward with that. So in essence, what does this all mean? All these changes, what does it mean for our critical access hospitals? And what it means is that practitioners, they order medications and tests, and they have the overall responsibility for the care of the patient. I see when our slides moving back and forth, my picture moved around here. They really have responsibility for the utilization of services. The good news is they're primary care based, but you think, well, I run a hospital. What's the deal? Well, if the physicians and the practitioners that are involved with you are subject to their reimbursement based on how they order tests and the number of tests, it will eventually impact your hospital. And if you certainly monitor and or own their practices, we have to think about it from that accord. So that's where it starts falling on the bottom line of hospitals. And it's simply, what's going to happen is order patterns are going to change. And I found this neat little outline that pre-MIPS, MAC, or whatever, revenues grew the same as revenues grew for physicians and hospitals. I mean, I think we were growing at the same rate. That's just simply the volume system. We started adding a little incentives. The physicians' revenues declined a little bit because they were the first ones at risk. And our hospital revenues have just been slowly increasing based on what we're allowed. As we add in ACOs and patient-centered medical home, hospitals begin to take on a little bit of risk. Physicians take more risk. And so you can see there's an incentive for the physicians' revenues to go up, and our hospitals will decrease because order patterns will change. And then high incentives, when we get into advanced payment models, physician revenues will increase, and our hospital revenues will decrease unless we make changes in how we practice. So there really is a sense of urgency. As I was doing this great bleep came across, as far as a headline regarding from the RAND study that, now granted 2030 is what, 13 years away, but it begins to show that how it's going to impact hospital revenues and how we're going to have to think about how we're doing business and change our revenue service lines. And, the good news is that we've got some time to plan and make this adjustment. So as you're a critical access hospital or small rural hospital, you have to think, what is going to be my business options? How am I going to do this? And I think there's been many, articles out there about the difficulty of being alone, and particularly with physician practices, they're saying that it's going to be very hard for them to participate in MIPS being all by themselves, and they're encouraging, even I'm seeing movements that there's a lot of virtual connection, like one physician practice might be connected with two others in another state, so that as a group together, you become a volume. With ICANN and our ACO, we talk about interdependency. If you're not part of a system, then groups of independent hospitals can come together. And so you almost have to have enough volume in dollar amounts to really have an impact and be able to sustain your risk over a period of time. So you can look at becoming part of a system, affiliations. There are all various types of approaches, and our hospitals in Illinois are looking at that. You can become part of an ACO as an independent. You can be part of the ACO as a system, partner with a resource hospital. The most important thing is that you really have to do something. You have to begin to plan down the road, is how are you going to manage under this new payment system that we're slowly moving towards. And I don't think, it's going to happen overnight. It's going to be an evolution over the next, 3 to 5 years. But if you do nothing, if you just say, I'm just going to do, as we do business today, slowly people will work around you and your business will, move away. So, really, Pat, what's your basis for this? What are hospitals doing in Illinois? And so in 2014, we started hearing all this verbiage out there and all this commotion about population health, and we really gathered together and said, what are we going to do if we move towards population health? And we're hearing payment changes, it hadn't happened yet. ACA was kicking in, and so our hospitals that really were the independents said, we'd rather be driving the bus. What if we jump in this ACO arena and see what we can do? So ICANN agreed to spin off an LLC and became what we call the Illinois Rural Community Care Organization. We applied to be a Medicare shared savings program with no downside risk, with the intention we're just going to learn. We're going to learn using Medicare because it was safe for us. There really wasn't a cost to participate. We have to put skin in the game, but we would learn. And so we kind of mapped out, what our timeline would be. We felt the first year we're just going to understand the lingo. The second year we worked on processes. That's last year, is how we're going to start taking apart, and I'll talk about some of those things. This year we're looking at outcomes, and then in 2018, we have to renew our initial application with Medicare, and so we're going to have to look at can we move towards risk sharing, and how have we improved with our quality. So, in some regards, we wanted to begin to control our destiny as far as our hospitals in Illinois. So, what have we really learned, and why did we participate? We got it because we wanted to learn about our claims. Where are patients going? It's just amazing. Hospitals, they'll get their Medicare beneficiary list and their practices will go, well, I don't know that patient, or I thought I had these patients, and how come they're not showing up? Well, maybe they've had more of their care done with another hospital, and we didn't realize that. So it's beginning to help us to begin to build your panel. Who do you really have in your practice, and how are they utilizing services? Maybe you've heard me talk about, we've learned that one of our hospitals, and I come from a nursing background at hospital. I've been involved in this business a long time, and I know we do a good job, but it's hard to believe that in one of our hospitals, we had a patient visit the emergency room 150 times in 15 months. That's like 10 visits a month. And it just continued to happen until we started to taking a look at this. And so obviously some new changes have been put in place, but it's what you learn is just amazing. We had to start building towards care coordination, and I really think the real carrot to all of us. We said we'd learned with Medicare, but we're learning how we can better contract with our commercial carriers, Aetna's, and United Healthcare, Blue Cross Blue Shield, and so forth, is that if we can do a good job and we can manage our processes, we should be able to have good contracts with them. And they should want to do business because they can work around us. So, when you become a shared savings program with Medicare, they do an average cost of your beneficiaries, and it's hard to believe that in our 24 hospitals now, that our average cost per beneficiary is $10,600, and you multiply that by we're close to 30,000 beneficiaries. That's about $250 million of Medicare costs there. It's really overwhelming to think about that. Now, if you go from state to state, like I think in Indiana, their costs are around $9,000. You go into other states, their average cost might be $12,000. So a lot of it has to do with health and practice patterns. But for you to learn from this today is that when you start looking at risk and how to better manage it, you have to break down what your costs are. Is it an utilization, our primary care? Are we getting people into the primary care setting for better management, well visits? What's our downstream spend? We look at our costs and we're thinking, gosh, is it all critical access? Is it our swing bed costs? Is it our cost-based reimbursement system? We don't believe it's all that. We believe a lot of it has to do with downstream spend. They have a CAT scan at your place. They go to the resource hospital. They CAT scan is sent in, and maybe they go to Mayo Clinic, and then there's another CAT scan. Then all that is included in this total cost. And so if we can better coordinate that and track it and understand our practice patterns and utilization, then I think we can control a little bit of that downstream spend, which will be important. The other thing is you have to look at this is getting the culture change, moving to value and understanding how patients, receive care and how they're utilizing that. And that's a mindset change for all of us. We've been doing business this way for a long time, not only from the physician's perspective, but the bedside nurse to the lab manager and so forth. We were in this process about a year and a half, and all of a sudden we kind of hit a brick wall, and we're going, hospitals understand, yeah, we need to move to volume, and who cares about risk, and so forth like that. What's it in for me? Am I better just to stay as I am today? And we realized what we weren't doing is thinking about the return on investment for making change. Theoretically, we believed in it, but we really hadn't delved down into it. And so we started looking at what would be our return on investment. Why would we make these changes? Because most of our hospitals had done lean, they've done revenue cycle, and if we have to move to value, why? Why would we want to do that? So you have to kind of think about businesses around you, and so, the triple aim really comes into play. If you think about the Walmart businesses and the Targets and all of that, what they're doing is lowering the individual product or the individual beneficiary cost. And in doing that, obviously you have quality, but the goal is to increase your business line, and that's no different than what we had to do. We have to look at strategies. How are we going to keep our patients locally? How are we going to build loyalty? Is it through gap closures? Is it providing greater quality of care? I remember when I was at the hospital in Princeton, 15, 20 years ago, we had about 80% of the market share in Princeton. That's pretty incredible. Over the course of the time, it's filtered down to 45 to 50%. Not that the hospital has really done anything different. It's just competition. People are traveling more. We hadn't built patient loyalty. All those things come into play. And so we have to be a little more tactical in how we begin to do business. And so we've been doing a lot of work in understanding our market share and how we can improve that. Many of you probably have looked at the Advantage reports, and when I look at Illinois as an aggregate, where we are really the weakest is our market share. We've really simply given our market share away, and so a lot of our work is to reclaim that. We have to really focus on physician and practitioner alignment in the hospital. It's really a team approach. Years ago, we supported the practitioner. That was our goal, is to support the practitioner. And today, it really has to be mutual goals because, many of our hospitals now own physician practices, and we all have to be aligned if we're going to be successful and keep our business local. So, talking about our primary care, you can't just look at Medicare and Medicaid patients. You have to look at your commercials. I've hinted at a couple of times. We're looking at our self-funded programs. Many of our hospitals in Illinois have self-funded programs. They have 300 employees, and so we're looking at how we can better manage that. And then how can we take those same healthcare benefit analytics, and can we do business with our employers in our communities? Can we manage their health risk? And can we identify those patients that don't have primary care providers, and can we assign them? Are there different strategies in how we do business? Not that we're going to do all their drug screenings, but how do we get their patients aligned with our hospitals, and how can we improve their services? We have to look at Medicare Advantage and Medicaid. So as our ACO, we're really not looking at just our Medicare Shared Savings Program. Sure, we're learning with it, but we're also learning the skill sets that would be transferable to all the different payer class. And that's what you do as the organization is how are you going to do business and secure your market share for all those areas? And then at the same time, we're trying to strategize our primary care. We have to think about how we'll manage population and what kinds of activities or tactics or whatever we're going to do. 50% of your population are healthy all the time. Sure, they might need sutures or they have a sore throat or whatever. And you want to keep them healthy, encourage them to exercise. And so you're really not going to spend a lot of your money in doing that. You're going to have promotional things. And then you move to the other 50%, and that's where you start to target is managing your population. You have those with early onset disease, hypertension, cholesterol, and what are you going to do for that? And then you have full onset of disease, and that's where most of your ACOs targets, because those are your cost value. That's that 15% of your costs are in that bucket. And so if we can better manage their care, we can control the downstream spend, then we have a greater chance of improving that population and getting better engagement. And then the complex care, as you start to look at that, you can then compare tertiary care centers, your cancer centers. Where are they getting the best outcomes, satisfaction and cost, so it becomes the whole picture, and that you're managing your population as a group. And it's really not one person, it's all of us in together. But I think this is a nice blend that you can think about is look at your own population and how would you target each one of these areas, and what kind of services and what would your outreach be to that. So, one of the things that we have to do as our ACO today, and whether you're in an ACO or not, is when are you ready to take risk? And that's even in your own contracting with your carriers and so forth. Is there are a lot of challenges. We still have an unstable political climate, payment system. We're slowly moving toward value-based purchasing. We can't snap our fingers and be there. Right now, our rural health clinics are not subject to MIPS incentive or any penalty. And as you know, most of our rural hospitals have clinics, rural health clinics. I can tell you that the hospitals in Illinois, I have a few hospitals that have great financial reserves, but most of them, they're limited. And can you budget if you're going to risk share together? Can you budget a $200,000 loss if you're going to, risk contract? We're not quite there yet. There's no sense of urgency in the sense tomorrow that we lose all our contracts. I mean, we see the push to that. But, taking that next step to risk, it's not a do or die in situation, even though we know that urgency is coming. And so I think we have to look at how are we going to manage that process and how are we going to grow and move that way. And so that's really how our conversation really lends today. I think there are 6 areas that I think that we have to be successful at. And, and I've outlined them there, and I'm going to cover them in detail as quality, data, alignment, coordination, cost, and so forth. So let me break them down. Healthcare, whether you're in an ACO or not and where you're looking today, it's still local. I don't think anybody can take it away. And, sure, you've got those web-based, ask a doc or ask a nurse kind of thing. But bottom line, when you really need health care, for, particularly when you're early onset of disease or a situation, it really needs to be managed locally. And at least for the next number of years, I think we can be assured of that. But we have to be patient-centered, and we have to build that patient loyalty. Somehow have to be connected. It's kind of that old school loyalty that you really want to maintain. And sometimes we lose that, we need to build that loyalty by, being the best of the best. And that leads us to performance. And I think we have to look at, good communication. It's a lot of that, managing your cultural change and understanding the competencies. And that's what I'm struggling with right now as we look at our ACO. We move towards risk. I've got some providers and say, gosh, I'm doing a great job. I should get more money. Then other providers saying, well, it's one for one and one for all. So how are we going to deal with that? And how are you going to deal with that? And those are things as you get into risk is how do you incentivize? But, to do that, you have to lay the groundwork. And so you have to start building in benchmarks and expectations of what you expect. The next thing is data. And if you have a chance to get in the shared savings program or even look at your own claims, how do you measure up and how do you compare with others? And this is just a sample of our dashboard that we look at. And you can see we have our average cost per hospital or practice. And we look at that at monthly, and we're trying to break that $10,600 down into, our different areas. And I think, we don't like to measure, but we have to. It's the only way we're going to improve our performance. Or at least understand why one month the cost might be higher than another and maybe change our strategies and the way we approach things. And whether you're in a, getting your own claims data, you can at least look at what other companies are doing. Business today, they're constantly looking at, what are their healthcare costs, and so I think we have to be good stewards and understand, what our data is and design our risk and design our programs so that we can be as efficient as we can. And how do we compare with the other guy? We've got to have that competitive competency there. And critically, we all know that the practitioner and hospitals have to be aligned. And we're even looking at developing templates of job performances or job descriptions that not necessarily look at RVUs, but start looking at how many of our practitioners move their patients into care coordination programs. And how are they managing that? Moving into more outcomes. You still have to have productivity. You can't have physicians that are seeing 4 patients a day. I mean, you just don't get anywhere that way, unless they're critical high-risk patients, and that's a different model. But, for our primary care, our clinics, and whether you're a nurse practitioner, PA, or a physician, you have to have some kind of a volume of business, but you also have to bring that in. And we have to really work with our providers to improve the workflow. We know EMRs are really a struggle, and how can we improve those, and what can we do? We can't just blame it on everything. We need to sit down and map out, our communication strategies and build in our compensation for those that align. Care coordination, and I know there's a lot of discussion out there, and you're seeing program after program, and clearly that's really the ultimate of the triple aim, and that's a whole nother webinar, but it's really the crux of everything. It's the secret sauce, or whatever you might say about that. But you have to build some kind of process in there. Some hospitals do it by assigning it to one person. Some do it by a whole team, but you have to give it concentrated. You can't have a person assigned to do care coordination and in the inpatient setting, or you're in your clinics, and pull them every other day. The whole community of your hospital has to be committed to that care coordination, and you will begin to see the changes in your patients. It's amazing, what that does. We have learned so much about, we think we're giving good discharge instructions, and we have a high number of congestive heart failure and COPD patients that are coming into unnecessary visits in our emergency department. So we've been drilling down and figuring out, why is that? Well, I'm looking at our discharge instructions through our emergency department. Only 30% have had any self-management, and maybe 20% had an appointment with their primary care provider scheduled. I mean, we've relied on our EMRs to print out discharge forms, but our patients aren't reading. They don't understand how they're supposed to take their medication. One of the successful programs that we have in our group is they've really actually started visiting the patients in home, not through home health services, but they're high-risk patients. They're doing coaching programs, and they're doing home visits. And I can really see the results of that in, once again, building loyalty, improving the services. And as I said, it's a team approach. There's a lot of chronic care management programs. There's some return on investment with that, and really knowing your resource, and that's where your community comes into play. If you're dealing with self-funded employer programs, are you getting these patients into Weight Watchers and other kinds of programs? It's helping them understand how they can better manage the care. And sometimes we think that patients just aren't, they just don't want to do it. But I think a lot of it, we've done work with motivational interviewing, is, are we listening to our patients? What are their barriers? And so care coordination allows us to do that. Controlling your costs, we can spend hours on this, but looking at breaking down where your spend is, and you can look at that, your 30-day readmissions, your supplier costs, and I can talk a lot about that, but I share this with you is not so much whether we're doing good or bad, we always want to do well. But you can see how the challenges is trying to improve your cost and looking at your skilled nursing days. Is it our swing bed program, or is it our patients going to our nursing homes and they're utilizing their full component of Medicare available skilled days, and they don't need to be? We're all kind of following the money in some regards. But so, it's controlling their costs and understanding where that's going, asking those questions. The value of primary care, and I think this is where we can excel, is through their care coordination and huddles, readmission huddles, short, bringing people together. I know it's become it's like the team huddle in getting the play together, and we're using that in all different settings in our groups, and I think you can use that, and I know it's been promoted for a number of years through patient-centered medical home, team steps, and all those things, but it's really the reality. One thing we've learned is that we have to do a better job of our coding. When you bring people in for a well visit, make sure that you're identifying all their chronic diseases. Now, this is particular with the Medicare patients. You have to do that. Otherwise, Medicare thinks that you have a healthier patient, and they think they're paying you too much. So you really need to look at it. And it also allows you to close those gaps, getting those mammograms, getting the colonoscopies. And you can actually see the ROI of 6 to 1 when you start measuring your transitional care, your chronic care management gap closure. For every dollar spent in this arena, we get a 6 to 1 return. And that can also be another conversation. In transfer process evaluation, and we're really honing in on that and really doing some education with our nursing homes so that we have better communications in place. And I just went through the primary care revenues. I think we can go back to Jerry Maguire, and he actually was on the Stars last night in one of the movies. Like, oh, Jerry Maguire, and it's really show me the money. And, we have to do that. When we're moving to different models and different payment models from cost-based reimbursement, I think we'll continue with that. We'll have some flexibility, but we have to be prepared to show the money. We have to be able to keep our doors open, and so you have to look at other options and build that, either building in greater volume, and expanding your market share in business, and or adding these other kinds of new primary care revenues. CMS is building new codes all the time for chronic care management and advanced care planning. So what does our rural ACO look like? You can see we're kind of peppered throughout the state. We have 24 hospitals and 35 clinics, and we're about 30,000 beneficiaries. Now we lose some in attrition, but we're in our third year. We have some investment funds, and we're getting ready to start a Blue Cross and Blue Shield program next year. We're getting our claims now and be ready to move to their shared savings. So I think sometimes it's just a visualization of what we're doing. Doesn't mean you have to look like us, but I'm just giving you an example of how we've been able to manage it. And I really say that we're kind of the inchworm effect. We know we need to move it, and we're taking steady progress as we move along. And I think most all of it, you will have to do that. But you have to take calculated steps. You have to be thinking. And I know as soon as, with the new administration, we say, oh, all our work, ACO is all going to go away. No. It goes back to when you pass MACRA and MIPS, it's the physician incentive program is going to change how we model our health care for the future. And so it's not going to go away. Will our ACOs and our transitional care models and all that look what they are today in 3 years? No, probably not. We hope they morph into something better, but it's not going away. We're going to have to be ready for this. And what should my hospital do? And you probably have done this already, and I'm hopefully maybe affirming what your steps that you've taken, but you have to look at your hospital situation. How controlled do you have of your primary care? Can you manage that? Do you know your business? Have you begun that transformation? Have you started looking at care coordination? When your patients visit primary care and they need to have a specialist, do you have a program in place that you can track when that patient goes to specialist or to a tertiary care that the patient comes back? We just don't send them off. So often we do that. but are we getting them back, and are we building programs that we keep our patients' loyalty local? Inventorying your financial resources is if you're going to move towards a little risk-taking, you're going to have to, look at your financial reserves and set goals and learn from each other. And I think most importantly, you have to begin to change the conversation. It's not business as usual, it's business of the future. And you have to look at your options. It's what we did in Illinois. Fit everybody else? Probably not. But at least you can learn from our examples and build them into your own strategies. It's still a volume world, I believe that, and will continue, obviously, have to be paid for our services rendered. Billing and coding are going to be relatively the same. It'll change and tweak from time to time. But you have to look at what your business model is and what kind of business are you going to build? Is it going to be primary care? Are you going to specialize? Are you going to come up with some risks? And obviously value has to be built into it. And look at what the impact the airlines has as they moved, away from looking at value and what kind of problems they've gotten into with United. I mean, there's no, those things can happen to our hospitals. So if we can build systems in place that control our quality, then we can control our risk and our costs and things like that. So spend your time on rebuilding your primary care and make sure that your physicians and your practitioners and everybody's in line, with our incentives. And I truly believe rural can lead. I think we've got the best of the best, and I'm fully committed, live in a rural area. I've been all my life, and I believe in the rural community and that we can do a lot. We can lead. And care is still local, regardless where you live. Be able to change quickly. I believe we're community focused, and we know our patients well. Let's take advantages, use them as assets, take it as competitive advantage, and most importantly, put our patients first. And I do think that we have done that over the years. We just need to enhance that and improve that. And I think as we focus more on primary care and we rebuild and we understand what we can do well and look at the ROI, I think we'll be there in a short time. So I leave you now with my thoughts. As I said, I believe that we can set our own destiny, that rural can lead, as I just mentioned. We took that next step, and that's, I think I've asked the hospitals that invested into it, do you believe that this was the right step? And they believe whether they, it would end tomorrow that they've made that right change, that care coordination and managing your population, better understanding your costs and so forth have really made a difference in their vision for the future. So I hope I provided some ideas and maybe affirmed some things that you've been moving towards, and certainly entertain any questions.
Great. Thank you so much, Pat. That was excellent. If anyone has any questions for Pat, you can press *2 to unmute your phone line, or you can type your question into the chat box. I'll just give folks a moment here. But oh yeah,
sure. I have to say this was not an easy one to do. I had to think about value and how you build a business, the financial model, and I realize that we've been doing that. But if we all had the roadmap, we'd be millionaires today. We'd know what the direction would be. But it's certainly clearly the direction we have to move.
Mm-hmm. Absolutely. Well, I think you did such a good job today that no one has any questions at this point.
Well, thank you again thank you again for inviting me, and best wishes. And anybody can contact me. Just use my email, and if you have a question. And thank you, Kim.
That sounds great. Yes, thank you, Pat. And in 2 weeks, we'll have part 2 of this alternative payment model series, where Dr. Greg Davis will be speaking a little bit more about his physician perspective of alternative payment models. So stay tuned for that. I think many of you are registered for that, and that is May 17th. We just added one